Now it says Kristen Miller is the host.
Chris is on now, so maybe she can save us.
Hey, Chris. So you're the host, Chris, so I can't record.
And you're muted.
And you're muted.
I just unmute myself. It is recording now, but
Okay.
I have to tell you, I have some serious computer issues. And so I'm wondering if I can...
Make me the host?
Yes, sir, make you the host.
Chris Miller was the host. So I was supposed to be a co-host, but didn't work apparently. So she's trying to switch it over. Oh, you did? Hey, Chris, Erin thinks she got me permission to record.
Okay.
I'm going to hit record, and now it's recording. All right, now I'm going to hit stop recording. Stop recording, so that'll be a fragment. And then, Chris, you're going to take yourself out of the screen, right? No offense, not that we don't like seeing you.
According to my view, it says it's still recording.
It might be recording twice because it's not recording on mine. And that's the one we're going to keep, is the one on my computer. So even if Chris is recording, that's not going to be. It's interesting. It makes sense you could record on multiple computers at the same time, right?
Yeah, I tried it when you were having trouble and I didn't have permission.
All right, here we go again.
Same here.
Everybody's ready? Take two, that's right. From the top. All right. Hello, my name is Jim Nataro. I'm the chair of the Department of Pediatrics at the University of Virginia. I serve as co-leader of the hub core of I Thrive, which is the Clinical and Translational Science Award Program held by UVA, the Inova Health System, and Virginia Tech Carilion. The role of the hub is to promote sound and rigorous clinical research, and we have therefore undertaken a project to improve recruitment of historically underrepresented subjects into clinical research studies at our institutions. We are recording a series of podcasts to capture best practice approaches to address such recruitment issues. Today we focus on enhancing recruitment of rural subjects. I have with me today three highly qualified discussants on this topic. Angela Scarpa, PhD, is professor of psychology at Virginia Tech. She is a licensed clinical psychologist and founder and director of the Virginia Tech Autism Clinic and Center for Autism Research. She conducts research and provides treatment related to the mental health and adjustment disorders of children, adolescents, and young adults, with a focus on autism spectrum disorders and disruptive behavior problems. Her work also seeks to promote evidence-based services throughout the lifespan, including assessment, treatment, and other supports. Her newest project aims to address health disparities in rural communities with respect to overcoming the barriers that these families face for accessing appropriate autism services for their children. Welcome, Angela.
Thank you.
Jamie
Nice
Zoellner.
to be here.
Thank you for coming. Jamie Zoellner, PhD, is a professor and registered dietitian in the Department of Public Health Sciences at the University of Virginia, where she provides leadership for the community-based health equity research program. She also serves as the associate director for the UVA Cancer Center Without Walls. Her research addresses engaging rural and medically underserved areas in community-based participatory research and discovering solutions to the causes and consequences of limited health literacy. She focuses on lifestyle risk factors such as diet and physical activity that have direct relevance to obesity and cancer. Dr. Zoellner's research projects are funded by NIH and the PCORI. Welcome, Jamie.
Thank you.
Kathy Hosig, PhD, MPH, is Associate Professor and Director of the Center for Public Health Practice and Research at Virginia Tech. The center is housed in the Department of Population Health Sciences in the Virginia, Maryland Regional College of Veterinary Medicine and is supported by the Institute for Society, Culture, and Environment. The mission of the center is to foster interdisciplinary collaborative public health practice and research activities at Virginia Tech and among external public health agencies, organizations, practitioners, and researchers. Dr. Hosig has experience with developing collaborative partnerships at the local and state levels for federally funded community-based projects. Welcome, Kathy.
Thank you.
So thanks for joining us. So I'd like to start the discussion today. I think, Angela, we'll start with you. And so please help us to frame the question. So why is it important to recruit rural populations, and why is it difficult? Why is this a challenged population?
Sure. I'll start with the first part of that question. Why is it important? Traditionally, oftentimes our research is based on samples of convenience. And so we end up getting samples that are kind of more of the majority population and not necessarily really representative of the people that we really work with. So we want to get as much information as possible so that our interventions, our services, our work applies to the most people possible in our country, if not the world. And that requires us reaching out to populations that wouldn't necessarily be able to get to us very easily. So that's why it's important to reach out to the rural populations. There are many barriers, many impediments to having these populations participate in our research projects. Probably the most obvious one is simply the geographic distance. It's hard for people in rural communities to get to us. So we have to come up with really creative ways to do our clinical research, not necessarily in our own clinic in the home base, but getting out there into the communities. So that's one thing that is difficult. And I think there are a number of other barriers as well. The trust issue is probably one of the biggest ones, where the universities and the researchers kind of come in and, we want to do this great research and we have all the answers, and that's not necessarily the best way to approach working with rural communities. That we want to work with them. We really want to be partners with them. And so establishing that sense of a relationship is really important. There are lots of other reasons. Maybe I'll let Kathy and Jamie chime in here.
Sure. So I'll just make a quick sort of follow up to one of the points Angela mentioned in terms of just reach and representativeness. The listeners might be a bit surprised to learn that about 1/3 of the 8 million people in Virginia reside in rural regions. And so if you're really looking to think about how your research has broad application within your state, really paying attention to what's going on in these rural regions, making sure that you have representativeness is a really important piece of the generalizability of your findings. So just wanted to throw that point out there.
Yeah, I think building on that, just doing work only in non-rural areas doesn't let us understand or know whether it's going to work in a rural area. If you just think about people's daily lives, the daily lives that people are leading in rural areas compared to more urban areas are very different. And the things that matter to them, the things they listen to, the people they trust might be very different. The way they might be able to even act on suggested behaviors or treatments or any of those, or even access to the treatments, can be very different. So we really have to understand how what we're trying to do would play out in the rural areas. And the way we would know that is to talk to them and get to know them first and ask them and do some of that formative work to be sure. But if we don't even try to reach them at all, we're never going to know if it's going to work or not. And it could be a waste of resources as well.
It sounds like there are cultural factors at play, right? As some of these impediments and even with some of the interventions that we might try might have a cultural overlay to it. Okay, so that was great. Any other impediments that come to mind that we're going to have to wrestle with?
I think we didn't directly call out, in our virtual world these days, internet access, whether everyone has a phone, what kind of phone do people have, those types of things, if we're trying to reach people virtually, is very different also in rural areas.
Mhm. And I'll chime in too and say that even simple affordability for participants in rural communities to be part of a project, you know, they need to think of, do I need childcare? How am I going to get there? What's the cost of transportation? How long is it going to take? There's so many other stressors also in the lives of these individuals, you know, and it's not as easy as simply saying, oh yeah, I think I'll participate in that project. They've got to overcome a lot of barriers.
Excellent. So these are some of the impediments. So let's spend some time talking about how we can overcome them. And you're all very experienced in this area. So Kathy, maybe we'll start with you. So if you're focusing at the population and the community level, obviously you're going to be addressing all of the impediments that we just talked about. So what are some of the best practices to position yourself for success at the community and the population level?
Okay, I think I was thinking about this, knowing that it was coming, and I was thinking about, okay, what is my high level answer to this? And I think partnership is probably my key word to the high level, is that we can't go out as researchers and live in every community we want to work with. And that would be great, and spend time there and build trust personally. But the way that we do it, other than doing that, is to work with people who do live there and who do know people and understand ways to reach them. And so partnerships have worked really well in the work that I do. Two examples that I think of off the top of my head are churches. We've been working with a statewide association of Black Baptist churches for 10 years. And if you are working with someone who is well known within the community and they trust you, then that trust comes through when they're working, when you're reaching people that you're trying to reach. Another example is Virginia Cooperative Extension, because they have an office in every city and independent city and county in Virginia. And so people know them, they live there, and they trust them. So those are just two examples, but really just working through networks of people, networks of organizations, I should say, that interface with and serve the people in the communities that you're trying to reach really helps a lot. Schools are another example. So building trust, it takes time, but if you can build trust more of an organizational level, if we're talking about population level, so that they know what you're wanting to accomplish will benefit the people that they're working with and that they serve, that does a lot. And the other thing, speaking to time, is to build a relationship and not only focus on what you are trying to do, but to listen and find out what the other needs. A really great thing is, if we're a researcher at a university, we have colleagues. We have colleagues in every possible discipline you can think of. And so if our communities and partners express needs in other areas, we may not be able to address, but we can certainly try to connect them to other people who can serve those needs, to just show that we're listening to people and to partners, and they can trust us that we have their interest at heart. That goes a long way to being able to work with partners who do know the people and have listservs, or they have meetings that they can talk about our project, or we can go in and talk about the project. But if we go in cold, that's not going to be effective. If we go in with a partner beside us who talks about us and is genuinely trusting us, that really has made a huge difference in the work that we do.
Yeah, I think that's incredibly important. The establishing the university community partnerships is key to really gaining the trust and gaining the relationships with the people. We really need to have that. We've worked as another example, we've worked with community service boards. There are 40 community service boards in the Commonwealth of Virginia, and we've focused on ones in Southwest Virginia so that we can develop those relationships. And that's worked really well because they already have been in the communities and have been a gateway for serving people with mental health needs. And it's been a wonderful way for us to be able to make that outreach and establish those connections.
So I like the perspective that you have to lead with benefit, right? So if you go into this community and you establish the partnership and you approach the community, you're not exploiting them for the sake of your own, to advance your research, advance your career. There's a benefit to this population. So it's one thing to say there is a benefit, but you know, is that authentic? So what are some of the sound bites when you come into the community to say that yeah, our university, which they may have never actually visited, you know, is actually going to benefit you in the following ways. So what are some of those benefits that you articulate?
Yeah, so I can give a few examples of some of the work, just extending from what both Kathy and Angela have said. In my line of research, we partner a lot with rural healthcare systems, you know, the federally qualified health centers, the community health centers, the critical access hospitals. And, you know, often when we're approaching these systems to think about collaborative projects, really we're thinking more not just about how we can study their populations or study their patients, but how we can actually serve their patients. You know, these this network of rural healthcare systems, they are already stretched extraordinarily thin. They're chronically underfunded. You know, they have very little resources to focus more on some of the preventative health behaviors like we would like for them to be doing. And so for them to agree to be a collaborator or to be a research partner, it has to be more than just we're trying to study your population. There has to be some sort of service piece to that, and thinking about not just how we can enroll or accrue patients into a trial that we're interested in, but really thinking about the potential to have whatever is happening in the context of that research project to stick within that organization. You know, a lot of what my team does is around obesity prevention and treatment and around cancer screening. And so we're going into these rural healthcare systems thinking about what the end product might be, you know, thinking about what this program might look like if it's actually able to be implemented and sustained through a system. So I think that's just a really important piece to think about. It's not just how can we better study rural populations, but how can we better serve them through the research that we're doing.
That's a really, really excellent point. And it shows the benefit that you're asking about. And I think it makes me think to take what Jamie said even more obvious is capacity building, so that when we work with our agencies and we work with people that these agencies serve, we think about ways that we can help those agencies better serve their clients and build their capacity. If it might be evaluation or it might be grant writing, so that we can, if they've expressed a need while we've been partnering with them and we know about funding opportunities because we know about those at the university, are there ways that we can either help them write a grant proposal, or in our case with the center, we serve as the evaluator. A lot of their SAMHSA grants or other kind of grants, CDC grants, they require an external evaluator. So can we help them by serving in that role? But again, just listening to them while we're working with them and seeing ways that we can help them either with other partners at the university or building capacity. And that builds the trust, and then they'll continue to work with us and certainly tout our studies to people because they know they're not connecting them with people who are just going to use them as study participants.
And I think the idea of integrating the service with the research is absolutely critical. When we're working with these populations, and all of us here, I think we're preaching to the choir, and that we all want to be able to conduct research that ultimately has a benefit to the community, a health benefit, physical health benefit, or mental health benefit, but we want something that will ultimately be able to be used in that setting. So listening is a great idea. We, prior to the research, trying to understand what the needs of the community are, what is it that they want, what would actually be helpful, not just from our point of view, but from their perspective. is really important, and then working with the leaders and the stakeholders in that community to design a project that actually will address those needs. So that's kind of like even before conducting the research. And then on the other side is, will the research actually inform the best way to serve that population? Because what we do in Blacksburg, for example, might not work when you're out in Abingdon or Marion or Galax. So we need to understand from a research perspective, can we collect data that will show us what is the best delivery format? So we've been doing things like, we have a mobile clinic. Is that actually helpful to provide in-person resource services on an RV? How do people like that? We also do telehealth. How does that compare to our in-person service provision? So things like that that can actually inform what's the best way to deliver the services to the community.
I think related to that, Angela's making me think about the mixed methods where we don't just collect data points and outcomes, but also experiences in the projects. How are people feeling about it, both the participants and the people who are delivering it in the communities, so that we know how people are experiencing what we're trying to do and what are ways that we can make it better, what's working, what's not. And that's another way of showing that we care, that we're not just coming in, doing our thing, collecting our data and we're leaving. We want to hear, how is this working for you? Is it working for you? How can we improve it? And that also helps with future projects, also helps the project that you're currently working on.
Excellent. So now we are positioned for success, as it were. We're in the community. We've delivered the value proposition. We are here not just to study, but to serve. You have secured the partnership and the trust of some local leaders or institutions or individuals who have gravitas and the respect of the community. So now you've got your subjects, and now it's time to enroll them and to secure their informed consent. So Jamie, so there are some challenges with that. You know, as we've heard, some of these populations, you know, we work for universities. We've got lots of degrees among the four of us, and in some of these populations, the culture is different. They may not have the same education that we do. There may be some other cultural and other individual barriers where they may not consent as commonly as we'd like. So what are some of the best practices at individual level to secure that informed consent?
Yeah, such a great question. You know, three main talking points sort of come to mind, and because our group has struggled with this, you know, we've been doing research in rural populations for about 2 decades now, and these are persistent issues. But one is your recruitment material, you know, 2 is your informed consent, the language and the literacy around that, and the third is, who is the face of trying to actually get informed consent from your participant? So maybe I could just walk through each of those really quickly. You know, with the recruitment material, really trying to put that recruitment material into the hands of your stakeholders and potential participants, and getting feedback on the images around it and the language around it and the branding around it. You know, one of the things that we've had to fight pretty hard with our IRB around, but have gained some traction yet, is having recruitment materials branded with different stakeholder organizations, right? If someone sees a recruitment flyer and they see UVA on it or Virginia Tech on it, that might not mean a lot to them. But if they see their healthcare system or see a church or see some other group that they're affiliated with, that might be that extra motivation or that trust factor that draws them in, versus if it's solely a university funded project. So I encourage the listeners to really, to really encourage the stakeholders through the development of their recruitment materials. In terms of the informed consent document itself, you know, again, one of the biggest struggles that we have is just sort of the template language that our IRB requires, and sort of the risk aversion that our IRB offices have in terms of the types of language that we're required to use within those documents, but really doing the best that you can to make that information as simple as possible. You know, there's a lot of things that we can't change, but there's also a lot of things that we can change around sort of the reading level and the types of information that we're trying to convey through that consent process. And then my third point is just really about who is helping facilitate that. You know, a lot of us work with very capable research teams and have graduate research assistants or clinical research coordinators, and those folks might be fine, but it might be better to be partnering with other members who are trusted within these organizations. And sometimes there's extra steps involved. Sometimes we're having to put our community stakeholders and get them IRB certified, but those are things that we do when we're trying to build this capacity and build this trust. So I will say that it's the hardest thing that we do, you know, actually recruiting rural populations into trials. I think all of us here have probably been doing it for a very long time, and it's still the hardest thing we do. You know, oftentimes once we get them recruited, you know, working on some of the engagement, working on the retention, you know, those things can also be challenging, but it's always that first step of just actually getting them to enroll that's the most challenging. So I just encourage people to, you know, to be forward thinking in terms of what that looks like. There, you know, and the process can take a little bit longer, but I think in the long run can really pay off.
And I'd like to put a plug in exactly what Jamie's been talking about. Our Community and Collaboration Core with iThrive offers community studios to researchers. And this is one of the things that the community studios could help with. If a researcher has a particular research project and they want to recruit certain special populations, including rural populations, to conduct a community studio with people who represent that population and go through the recruitment, the consent process, and just say, what do you think about these documents? What do you think about this informed consent form and how it would play out with your friends and neighbors? And get that up front so that there are no surprises moving forward.
I think it's also important to recognize that as researchers or clinicians that we're obligated to really have an understanding of the people that we work with. And if you're working in rural communities in Appalachia, for example, understanding and getting some training on what's the history. Why would somebody in these communities be afraid? There's a real fear of sometimes working with professionals, and it's a valid fear. They may have reason for that based on their own histories or their family's history and their experiences working with different service agencies. So we need to be really sensitive to that and understand where they're coming from, why that fear would be there, and explaining you know, why would we be any different, and how can we be there as a help and a support instead of somebody to be afraid of.
Yeah, and I'll just, you know, I'll piggyback on that just a little bit, because I think that in our experience, a lot of the training goes both ways. It's training the research side on what are the needs of rural populations, and it's also training our rural communities on what is research. You know, I do a lot of social and behavioral research projects that will never involve any sort of drug, will never involve any sort of clinical measure that's taken. But a lot of times when individuals hear a trial, they automatically think it's a drug trial. They automatically think that they're going to have to travel long distances to have a lot of clinical measures. And that's the case for some of the clinical trials that are being conducted at UVA and Virginia Tech and nationwide. But there's also a lot of work, including the work that all of us here are doing on the phone, that oftentimes don't fit that clinical stereotype of what a trial is. So I think it kind of, that training piece I think is important on both sides.
And I think to piggyback on that, if it is a trial, if it's a drug trial or a clinical trial that involves any kind of medical intervention, for people to understand what are the measures that are in place to protect people, because people do, you know, hear the horror stories from the past that hopefully don't happen as much now, but what are the protections that are in place for people who are research participants? It says it in all that mumbo jumbo on the informed consent, but to give them a heads up, you know, there are ways that you are protected if you're a participant, and you're not going to be put at a disadvantage in any way. So I think that was a really good point to bring up.
You know, I like what you said about history. So, you know, Americans are not a people that are sort of famously attracted or interested in history compared to, say, Europeans, for example. But horror stories we love. So if there are horror stories about how research has been done badly in a community, in particular in a specific community, you can probably be certain that everybody knows those horror stories. So yeah, good to know the history and what has preceded you. I presume all of you are experienced investigators. I presume that you've all gotten better in this space over time. You've learned lessons and maybe even made mistakes and then not repeated those mistakes. Is it a good idea if someone, so I think you've convinced investigators listening today that it is worth their while to approach and include rural communities in their research. Is it a good idea to find somebody who has some experience in this space for a little bit of mentorship, perhaps to interface with an experienced team?
Yeah, absolutely. But we spent a good couple of years getting some consultation before we went into the rural communities. We had some folks in our Appalachian Studies department speak to us, and people from other universities to understand what is the culture of rural communities, what do we need to be sensitive to, how can we be real and be sincere and genuine with the people that we work with. And I think all that is really important. What language we use, understanding even different terminology that might come out of different communities, and also not getting stuck in the stereotypes, because we all have stereotypes and biases, right, of what we think we're going to find, and how can we overcome some of those stereotypes.
Excellent. And maybe just throw in there, Angela, that yeah, when we may stereotype rural communities as a homogeneous entity or a homogeneous, you know, population. Of course, cultures can vary, and so I would not assume that the culture of rural Appalachia and the culture of rural Delmarva Peninsula are exactly the same. So doing your homework and understanding the cultural overlay sounds wise.
And
Other
working
thoughts?
with the families, working with the actual people in the community, conducting focus groups, really establishing those ties with them. And I remember speaking with families and just asking them, like, I'm an outsider, I'm coming in, I have a different accent from you, I come from the north. How is that going to affect building those relationships? Would you even want to work with someone like me? And I was very worried about that, and that all of the families that we talked to said, well, if you're genuine and you're not talking down to us and you treat us with respect, we're going to see that. And that is really what's important. So that really stuck with me. It's your genuineness that's really going to come through.
Excellent. Well, thank you, ladies. It was a great education for me in this particular space. I really appreciate your time. And on behalf of—
This is really fun. I think for all of us, this is like what we love. So it's a wonderful opportunity to really, even to see, for me to see Angela and Jamie and just hear what they have to say has been really wonderful.
Yes, it has been. It's been a pleasure. We should do it more often.
Thanks to all of you on behalf of iThrive, and best of luck.
Thank you. Bye.
Thank
Bye-bye.
you. Thanks for having us.